meeting. Let's start. I think you have enough 2 minutes stretching your feet. Good afternoon, everybody. I like also to greet and say hello to our friend and colleagues in Gaza and in Yemen. Of course, for us, the Yemeni members of the GHA who could not attend this meeting this year, we miss them. And I will tell you, يا من يعز علينا أن نفارقهم وجداننا كل شيء بعدكم عدم. Inshallah, I hope in the next meetings you will be with us. We will have a question from Yemen and Gaza after the session. We will start the first meeting and my colleague Dr. Hoffman will introduce.
Okay, well, on behalf of the American Heart Association, Dr. Sidney Smith from the University of North Carolina is going to talk about the new American Heart Association, American College of Cardiology Guidelines for Hypertension, background and important changes. Sid.
Could you reverse that to the first slide? One more back. One more back. Can you reverse? One more. Let's change the colors on the slides, so I hope everything will work well. Well, thank you very much for the invitation. It's an honor to be here and to come back again to the Gulf Heart meetings. My last visit I very much enjoyed, and this has been the same. I'd like to thank you for your hospitality and everything that has been so much fun for me at the meetings. I'm going to talk about the, thank you, Guy. I'm going to talk about the new hypertension guidelines that have just come out. I was on the writing group. I was also on the writing group and chaired the NIH guidelines for hypertension. So what I will do is to start off with the evidence base that was established and try to explain to you how we got to where we are. Where does all of this come from? So we'll talk about some of the important changes in background and then finish up with a few words about the new guidelines. One thing that has not changed has been the focus on lifestyle. It's very important and frequently neglected, and that is the benefit from weight reduction. If we had a pill that could do this, everybody with hypertension would be on it. From the right eating, from the diet, from reduction of sodium, physical activity. So this must occur in all patients who have elevated blood pressure and beyond. We'll talk a little bit more about that. And those recommendations are not changed. Shown here is the JNC8 committee recommendation that you're all probably familiar about. This was published in 2013, December, and it was a strict review of evidence base. For those of you who don't like to read through long guidelines, this was a guideline for you, 13 pages and 9 recommendations. And it was the first really purely focused evidence-based guideline generated. With evidence and with all of these guidelines, we have to move from what we see on observation. As shown on this slide, we know that as systolic blood pressure goes up, that the incidence of cardiovascular events go up. The question is, if we treat with a pill and lower the blood pressure, will the events go down? And if we do treat and the events go down, where do we start treating and when do we stop? And what's the evidence for all of this? Now, that was the challenge that the committee at NIH faced. We did have $22 million to do the 5 guidelines, but it took 5 years and a very extensive review of evidence. Now, this is a slide which those of you that were here for Dr. Huffman's excellent presentation saw. Now, what this slide shows and points out is that there is a clear and consistent increase in events as systolic blood pressure goes up. The important observation from this slide, beyond that relationship, is that there is a difference in the frequency of events based upon age. This should tell us immediately that we can't just measure blood pressure and treat without knowing what other factors are present. And for the first time, the new guidelines bring in the issue of risk. So you can see that for an 80-year-old, there is definitely an increase in events, but the number of events that are occurring, the percentage of events are much higher at age 80 for a given blood pressure than they are at age 40. And the Europeans have been using risk for a long time. Rod Jackson in New Zealand was actually the first person to use risk in the development of hypertension guidelines. So this is a very important observation, and you'll see how it worked out. The other thing that we do know, and this is a summary of a variety of studies, that reduction in systolic and diastolic blood pressure has a significant benefit on events. Stroke, heart failure, a little less on heart attack, but that lowering blood pressure does reduce events. So the question is, where do we start and what should we do? Now, at the same time that the work was going on at NIH, the Europeans were revising their guidelines, and I want to call your attention to this right upper. Let's see if I can show the pointer here. No, this doesn't work. These don't usually work very well. If you look in the right upper side here, you can see the adults. See if this will do it. Yeah, move it over here. The adults, the evidence in adults is shown here. Do you have a better pointer? About the same, yeah. We'll work with it. So, and you can see across here, the dotted line is 140, and at the top is systolic blood pressure where the adult's treatment began, and green means that it worked and they were treated to this level. If it's red, there was no benefit. And so from the European analysis, what they found was there was really no good evidence that treating older patients to a blood pressure of less than 140 had any benefit. Now, the starting blood pressure was in the high 140s, low 150s. So the only real evidence existing 3 or 4 years ago from a purely systematic analysis, very strict review, was that in older patients, the treatment to less than 150 had strong data to support it, but there were no good studies treating older patients to less than 140. The other thing that existed at that time were there 3 major guidelines. JNC7 said that thou shalt use diuretics as your first drug. Why? Why was that? Because of ALLHAT. ALLHAT was a very important study with regard to JNC7 in the United States. The Europeans said, as far as we're concerned, you can use anything that works. If it lowers blood pressure, use it. You should get a benefit. The British said, no, not too fast. Frankly, we don't like diuretics, and we really don't like beta blockers. So there was an argument among 3 major guidelines as to what drug to use and when to use it. Now, in the review that was conducted in the JNC8 panel, you can see that those 3 studies that lowered blood pressure in older patients to less than 150 had significant benefit, as shown down here. However, in the 2 studies that lowered blood pressure to less than 140 in older patients, there were no significant benefits. So the committee came out and said, based on the evidence, and they were told they could not say anything if they didn't have any evidence for it, that in the general population that was over the age of 60, they should be treated if the blood pressure was greater than 150, and it should be definitely lowered to less than 150. This was a bit different from the existing standard of 150, and so the committee came out with a corollary recommendation, which is not quoted very often, that said if you treat them to less than 140 and they're tolerating the medications, it's okay. No need to change the meds. And so there is an issue about treating high blood pressure in older patients. There's also a major question about diabetes. Previous guidelines had suggested that patients with diabetes should be treated to less than 130. The Accord trial tried treating them to a blood pressure less than 120 and failed to show a benefit in the primary endpoint, but did show a reduction in stroke, which was a pre-specified secondary endpoint. So there was no evidence in patients with diabetes from a primary endpoint that there is any value to treating less than 130. Finally, there were some signals. For instance, in the ALLHAT trial, black patients did not tolerate ACE inhibitors. In the LIFE trial, you can see that beta blockers, in this case atenolol, was associated with a higher incidence of stroke. And similarly, if we can get that slide to advance. Can you give me a hand with the slide? Yeah, this will do it. Yeah, and similarly, in the LIFE trial, the use of beta blockers, in this case atenolol, was associated with an increase in new onset diabetes. So based on this, the recommendations were to use one of three antihypertensive agents: diuretics, calcium antagonists, ACE inhibitors, with the exception of a situation where a compelling indication was present, such as previous myocardial infarction or heart failure, where beta blockers might be indicated. Arrhythmias or angina would be another such case. So it came out with a relatively simple recommendation. All patients should be treated to less than 140 over 90, with the exception of patients that were over the age of 60, and they should be treated to less than 150 or less than 140 if they could tolerate it. Patients that were African American should not be treated with ACE inhibitors unless they had renal disease, and beta blockers were not recommended unless there were compelling indications. Now, shortly after those guidelines were published, it became clear that there was a new gorilla on the pavement here in the room, and this is the SPRINT trial, which was a multi-center randomized trial that included patients over the age of 50. You should know these inclusion criteria because SPRINT does not apply to everyone. Over the age of 50, they had to have coexisting cardiovascular disease, previous stroke. They excluded patients with diabetes, stroke, kidney disease, or severe heart failure. And so the question is, how does this trial relate to the guidelines that just came out? Shown here are the data from SPRINT. The patients were treated to a blood target of 120. They achieved 121. The control group, if you will, the comparator group, was treated to 136. And the trial was terminated early because of a reduction in mortality, roughly 25% reduction. So there are profound benefits seen from a more aggressive treatment of blood pressure. The primary endpoint is shown here. It was largely powered, as you can see down near the bottom of the slide, by a reduction in heart failure. But also there was a reduction in overall cardiovascular death. Interestingly, there is no reduction in stroke seen in the SPRINT trial. And there were some prices to pay, and that is hypotension, and some of the predictable problems that would come up with more aggressive reduction in blood pressure, electrolyte abnormalities, and so forth. Very importantly, there were pre-specified groups in SPRINT, and I'll call your attention to the fact that none of these pre-specified groups failed to show benefit. Men and women both benefited from a more aggressive approach. The older patients benefited from a more aggressive approach, age 75 being a cut point. So the benefits that were seen in SPRINT apply to all of the primary pre-specified secondary endpoints. These are the data from patients that were over the age of 75, shown in blue. You can see a significant benefit here from the groups that were treated more aggressively. Now, how do these findings apply? And this is a dilemma that the committee faced. The actual patients that would have benefited by more aggressive treatment are shown here in this white circle out of the total group with hypertension. So how do we take the benefits seen in SPRINT and apply them to a broader population? At the same time that SPRINT was going on, a number of other important meta-analyses were published. This one, done by Etihad, showed significant benefits. You can see the dots occurring right here, here, and here for treatment to less than 130, showing a significant benefit to more aggressive treatment of blood pressure. And similarly, the study by Shea et al. Showing a reduction in events when blood pressure was treated to less than 130. So there is a growing body of evidence that in patients that had high risk or known disease, that more aggressive treatment would work. Just when everything seemed to be perfect, the HOPE trial came out. And you'll hear about polypills in the next presentation by Dr. Huffman. But the HOPE trial used a kind of a mini polypill, a small double-dose, fixed-dose candesartan and hydrochlorothiazide, and looked at treatment there. What they found was that patients whose blood pressure was up in the 140s benefited, those that were in the high 130s, no benefit, and actually possible suggestion of harm, a J-shaped curve, in patients that were treated whose blood pressures were at less than 130 and who were at low risk. So now we come back to this issue of risk, which may help us understand what's going on. Patients at high risk, patients with known disease, across the board, all the way up to ages over 75, with certain inclusion criteria, benefit from more aggressive treatment, but lower risk populations may not. The other important thing to know about is that in SPRINT, the blood pressure was recorded using automatic office recording. And the way that's done is that the cuff is placed on the patient's arm, who then sits in a room for 5 minutes with no one else around. They measure the blood pressure. That's not what happens in most offices. Frequently, a patient will arrive at the office late, come running in, have a nurse put them on a chair, put the blood pressure cuff on over the arm, measure it. That blood pressure is totally different than what might be measured in SPRINT. How much different is shown here. There can be up to 8 millimeter difference from the automated office blood pressure, that is a lower measurement than what could be recorded in standard office measurements. So how do we take the measurements in SPRINT, which are measured differently in a high-risk population, and apply them to the general population? So the conclusions at this point in time was there's strong evidence that lower pressures were better than higher if we're treating high-risk groups. The method of obtaining blood pressure is very important. If you use the automated blood pressure, it can be 6 to 8 millimeters lower. Lower-risk patients may not benefit from aggressive blood pressure lowering. We felt that more data were needed. We didn't have patients with diabetes in SPRINT. That's a big question. So the committee sat down with this and tried to make sense of it. In comparison to the JNC8 guidelines, which had 9 recommendations and 12 pages. The guidelines that just came out have 283 pages and 106 recommendations. So this is a different animal. This group, we looked at everything, pre-operative blood pressure measurements, everything across the board in terms of what should be done, and we're not constrained by the absence of evidence. In certain situations you'll find opinion. But I'm going to try to touch on some of the important changes. Very important is the reclassification of high blood pressure. Normal blood pressure remains the same, less than 120 over 80. Previously, in JNC7, you were told that you had pre-hypertension from 120 over 129, 130 over 139, all the way up to 140. So a patient walks out of the office and he's told you have pre-hypertension. What does that mean? Do I have hypertension or do I not? The committee now, the new guidelines say, if your blood pressure is over 120 over 80, you are at risk. You have high blood pressure. End of discussion. The question is, what do you do about it? The answer is you have to initiate the healthy lifestyle, the diet, the exercise, the things that I showed you in the beginning, between 120 and 130. If your blood pressure is over 130 systolic, over 80, you have stage 1 hypertension. Stage 2 would be over 140. At that point, in addition to the lifestyle changes, we introduce medical therapy. The basis for this, aside from the evidence that I showed you from SPRINT and the meta-analysis, is shown here. If you look at the 2 columns, you can see that there's a significant increase in risk when you go from 120 to 130 up into the 130 column shown on the far right. For stroke, for coronary heart disease, myocardial infarction, there's a significant difference in terms of risk. Now, how many people might be involved with this new classification? In the United States, you can see here, based on NHANES, roughly 45%, 46%, almost half of the people would be considered to have hypertension. And that translates to going from 72 million in JNC7 to over 100 million here. So we have now identified a larger group of patients as having high blood pressure. The recommendations for treatment are based on risk. If you have cardiovascular disease, you are at high risk, and your blood pressure is over 130, you should be treated medically to a target of less than 130. If your risk is greater than 10% with the risk predictor, you should be treated if your blood pressure is over 130. If your risk is less than 10%, you should initiate treatment when the blood pressure reaches 140, when it's greater than 140. So there are changes in the cut points. So is there any difference in the expected benefit from lowering blood pressure when we bring risk into the equation? The answer is yes, there is. We have data that show a significant benefit. The higher the risk, the greater the benefit. And so these therapies need to be targeted now. We're getting more towards something like what you've seen in lipid lowering. This gives you an idea. Shown on the bottom axis is the increase in blood pressure, and across this lateral axis here is risk. You can see that for any blood pressure, as risk increases, the events increase, shown over on the left. And that as the higher the difference in blood pressure, the greater the increase in risk. So you can begin to see risk correlated with differences in blood pressure and understand why the assessment of risk is so important. You can see that the NNT significantly increases as the 5-year risk increases in terms of benefits of treatment. Also entered into this are out-of-office readings, which are recommended for the diagnosis and management of hypertension. The importance is to diagnose those patients with white coat hypertension and also those that have mask hypertension. That is, they come into the office, the blood pressure looks good, and at home it's high. And it's also there to help manage patients that are on antihypertensive therapy. And Dr. Huffman gave a nice a summary of those recommendations this morning. In adults that come in with systolic pressure greater than 130 but less than 160, it's recommended that some sort of ambulatory or home blood pressure monitoring be performed before starting therapy. And similarly, in those patients that have known white coat hypertension, there should be ambulatory monitoring to try to get a better idea of what blood pressure is on an outpatient. These are the recommendations which are largely 2B, 2A. That is, it's reasonable to do this in patients that don't achieve the goal that are on multiple therapies. So finally, what did we do with diabetes? In diabetes, the recommendation was those patients with diabetes and hypertension should be treated to less than 130, even though there were no patients with diabetes in SPRINT. The evolving evidence from other studies and meta-analysis, we thought, presented compelling indication. The first line of agents should be diuretics, ACE inhibitors, ARBs, calcium channel. ACE inhibitors and ARBs are considered as first choice if they have albuminuria. Then finally, these are the data showing you that I alluded to from SPRINT and ACCORD. If you combine the studies showing the benefit of treating patients to less than 130, and most recently, the study that's come out using a post hoc analysis of SPRINT in patients who were pre-diabetic. Even though there were no diabetes patients, the pre-diabetic patients benefited from more aggressive treatment of blood pressure. So we feel that the evidence is fairly strong to support the target of less than 130 in patients with diabetes. In summary, under diagnosis, there are new blood pressure categories. Over 120, less than 120 over 80 is acceptable, 120 to 129, less than 80 is high blood pressure, stage 1, 130 to 139, stage 2, 140 and above. Out-of-office blood pressure measurement is measured. In making the diagnosis is recommended. The therapy, lifestyle must be recommended for all high blood pressure, stage 1, stage 2. Meds are recommended 130 over 80, greater than that if they have clinical disease or if they have a 10-year risk greater than 10%. If no clinical cardiovascular disease and the 10-year risk is less than 10%, start treating at blood pressure 140. The target is less than 130 in most of the cases. The first-line agents are thiazide diuretics, calcium channel blockers, ACE and ARBs. Beta blockers are reserved for those that have compelling indications: post-MI, heart failure, arrhythmias, ongoing angina. For stage 2 hypertension, when the blood pressure is greater than 20 over 10 above a target, you should start with 2 agents. And with that, I'll thank you for your attention and conclude my remarks.
Thank you very much, Dr. Smith. Maybe one question from the audience, please. Thank you.
Sounds like it's on.
تعال أعطيك ميكروفون هذا.
Come up here. Come up. Use this one. Come on up. It sounds like a good question.
I think many people in the world was waiting for these guidelines, and the AHA, when the GN8 came, nobody was happy about this short guidelines. But the way the guidelines came, it wasn't simple as we thought. There was a lot of influence of the SPRINT, especially the chairman, and at least another 2 from the committee was in the SPRINT trial. And the guidelines were put under fire by many people, including some experts of hypertension. So did the committee, when she had the final draft, was expecting this controversy and discussion around these guidelines?
I think the question was around the members of the of the Hypertension Guideline Committee were part of the SPRINT trial. Perhaps.
No, it's not only like this. The issue, the guidelines is not easy as we thought, the way it was in the final. Number two, at least the chairman of the committee plus at least two co-authors was from the SPRINT trial, and it was already under fire, the SPRINT, and this was a lot of issues regarding this. So it's not only some societies is putting the guidelines under fire, but some hypertension experts also, especially the target of the blood pressure was one size fits all for everyone. And also regarding the risk stratification of the guidelines was not used before in any of the hypertension guidelines. So what do you think about all of this?
I'm not sure I got all of your question, but it's a very good question. I'm extremely interested, stay up here, in the way we do guidelines. And I actually called attention to the issue that the chairman of this guideline committee was the PI of SPRINT. And so based upon that, and while this was an NIH study and so forth, still we took a fairly hard position that he was not allowed to vote on any recommendation where SPRINT was involved. He had to recuse himself and was not allowed to vote. So there are no major conflicts in terms of involvement within industry studies. Now, the other part of your question was the beginning. What was
Sid, maybe we could take this offline just because we're already running a little bit behind. But I do think it's important to think about how guidelines are created. We've tried to answer this question a couple times. And
how was the data discussed, organized?
Target was almost the same for everyone.
We can talk later about it. It sounds like a good question. Believe me, I'm deeply involved in this for 20 years, and I want things to be right. So,
thank you.
Yeah, thank you.
Thank you for the question. Thank you for the question. Thank you, Dr. Smith.
Okay, thank you very much, Dr. Smith. Our next speaker is Dr. Mohammed Zubaid. Is he around? Where is he?
There is.
Mohammed.
Yes.
Of course, Mohammed does not need to be introduced. He was the president of GHA until 1 hour ago, and now he is the former president. Yes, Mohammed, go ahead.
And to spoil myself a little bit, I say immediate past president.
Okay, immediate president.
So not past president, but immediate. So thank you very much, Dr. Hajar, and thank you all for staying this late in the afternoon for the presentations, but I'll be short. I know we're running a bit out of time, but the focus of my presentation is going to be we live in areas, we live in a region where primary PCI is not possible all the time, every time, and we have to use lysis. So how should we handle this? And is there a way to best utilize lysis? And so it's the role of pharmacoinvasive therapy. And when we talk about ACS in our region, so we've already looked at that several times, and about 40% of our patients present with STEMI, and the rest with non-STEMI and unstable angina. And we know time is muscle, and the earlier you reperfuse an artery, the better it is. So it's all about time. And I'm not here to tell you that primary PCI is not the best approach, because it is the best approach. And it's proven in many studies and meta-analyses. If you can do it, then that's the best thing to do. However, in reality, that's not the case. So this was from Gulf Coast, which we conducted in 4 Gulf countries. We had 4,000 and citizens, i.e., everything was available to them, fully insured. And yet the primary PCI rate in 2012 was as low as 0.3 and 5.8 in Kuwait, and the highest was in Emirates with 40%. And so yes, primary PCI is the best thing to do, but it's not being done. And I'm sure all the cardiologists in Kuwait and Oman and Bahrain, they realize it's the best thing, but It's not being done on the ground. And that's not just in Kuwait and these areas, but even several places in Europe and North America. And there's this issue of door in and door out. The patient presents to a hospital without primary PCI, and they have to be transferred, and there's further delay and so on. And we know that when primary PCI is delayed, of course, the earlier you give it, I don't think the pointer here works well, but the earlier you give it, the better the outcome is. And when there is delay in giving PCI, the mortality, or primary PCI, the mortality is delayed. And therefore, the European Society of Cardiology, the American Heart, American College of Cardiology, they all recommend primary PCI as the best therapy in the first 0 to 3 hours from symptom onset. And fibrinolysis is only if PCI cannot be performed within 120 minutes from STEMI diagnosis. And then when you move from 3 hours to 12 hours, still primary PCI is the best option. And fibrinolysis, you get that yellow color on it, so it becomes less effective as time wears off. So is there an in-between strategy? So I cannot do primary PCI. What should I do? And this is called pharmacoinvasive therapy, where you recanalize the artery with initial lysis, and then within 6 to 24 hours, you send the patient to the cath lab. This is different from facilitated PCI and rescue PCI. This was studied actually by the STREAM investigators, Paul Armstrong and colleagues, and they looked at the option of providing primary PCI or lysis to patients who present within 3 hours of chest pain, but you cannot provide them primary PCI within 90 minutes. So they randomized them into 2 arms, those who would receive thrombolytic therapy or fibrinolytic therapy and then go on to the cath lab within the first 24 hours, and those who went on for primary PCI with the time delay. And then when they looked at it, and the pharmacoinvasive therapy, patients were cathed within 17 hours of the administration of lysis. And there was a minor superiority of primary PCI, but there was no statistically significant difference in composite endpoint of death, shock, CHF, and REMI. Looking at the specific single endpoints to 30 days, you can see the cardiac death, heart failure, cardiogenic shock, and reinfarction were the same. When they looked at stroke, and that's everybody who gives thrombolysis, lives with this thing. And the stroke, you can see that the total stroke with a p-value of 0.03 and hemorrhagic stroke 0.04. So there was a small difference. However, they amended the protocol, and patients over 70 or 75, I can't remember right now, were given half lytic, and then there was no difference in total stroke or hemorrhagic stroke. Based on the STREAM trial, based on the data we have in Kuwait, and based on our findings from Gulf Coast, we decided to test this approach in a registry fashion. So we did what I call the focused observational registry that examined patients who received reperfusion across all of Kuwait for 1 year. So we took everybody who got reperfusion for 1 year, and we said, let's just see how they get treated, and we're not going to interfere with their treatments. So we had about 1,200 patients, and you can see the age, young age, majority male, and interestingly, 20% of the patients younger than age 45, and the over 65 are only about 10%. So these were patients who presented with ST elevation MI across all of Kuwait, and they received some kind of reperfusion. So we looked at what they received, and we did not dictate to the hospitals and to doctors what they should give them. And 50% almost received primary PCI, 30% received pharmacoinvasive, where they would get lytic, and then within 24 hours, they'd be sent to the cath lab. And about 16% received just lysis with, later on they would decide either they get in-hospital cath, but not within 24 hours, or outpatient cath. And so if we look at the hospitals, for example, then patients who received primary PCI, those who had on-site cath lab, and there were 3 hospitals with on-site cath lab, the median door-to-balloon time was 60 minutes, which is very good. But when it involved the transfer from a patient coming to my hospital and then transferring him to a primary PCI lab, it took 101 minutes with a 40-minute difference between the 2 hospitals. So there is an issue of time delay. And we looked at effectiveness comparing the two strategies, and the in-hospital mortality according to reperfusion, looking at the primary PCI comparing to pharmacoinvasive, 1.7% compared to 2.6%. And there was no statistical significant difference between the primary PCI and the pharmacoinvasive arm. There was no difference between the pharmacoinvasive and the lysis, but there was a difference in mortality and in hospital between the primary PCI and the lysis. But looking at the pharmacoinvasive therapy that we were advocating for, we felt it was associated with a reasonable in-hospital outcome. Just some of the patient characteristics to know what happens in our area. Symptom onset to hospital arrival was about 112 minutes, so patients came relatively in good time. Utilization of EMS, emergency medical services, is very low in our regions, and we've known that. And luckily, about 75, 3/4 of the patients would present to the hospital within 3 hours of symptom onset. And looking at the in-hospital mortality, comparing those who presented within 3 hours compared to those presenting after 3 hours, again, just looking at the pharmacoinvasive and the primary PCI, there was no statistical difference in terms of in-hospital mortality. And safety issues, interestingly, there was more transfusion in the primary PCI arm than there was in the pharmacoinvasive and the lysis. And this was mainly due to transfusion related to femoral punctures. And obviously strokes, there was a small number of strokes, luckily 0.5%. And the 2 hemorrhagic strokes that occurred, one in the pharmacoinvasive and one in the lysis. So people get lysis, they're going to be prone to strokes and hemorrhage. But it's interesting to see that even the primary PCR arm had strokes. It was thrombotic, not hemorrhagic. So, and we've seen that patients who undergo catheterization do get strokes if you follow them carefully. We had a good, reasonable follow-up. Remember, this is a registry of all comers, and this is really a challenge in our countries, and we've known that over the years. We have a 60% expat population in Kuwait, and a lot of the expats, when they get big events like MIs and stuff, they disappear. They go to their families and so on. So follow-up, whenever you include expats or all comers, it's a challenge. But we managed to get hold of, do the follow-up, and actually those who we reached was about 85%. This is the baseline characteristics and the unadjusted in-hospital and 1-year MACE. And if you look at the baseline characteristics between the primary PCI and the pharmacoinvasive, this was not randomized trial. The characteristics are same, except when you look at KILLIP class 2 to 4. And if you look at the composite endpoint of stroke, major bleeding, or death, it's the same in both arms, and then stroke, major bleeding, death, and so on. And this is unadjusted, and this is looking at the 85% of patients with full follow-up data with a primary PCI in hospital, 1-year mortality of 3%, 3.1, pharmacoinvasive 3.6, and the lysis, of course, is about 9%. So there's no difference between primary PCI and pharmacoinvasive in terms of the in-hospital mortality and the 1-year mortality. Again, and I'm not saying that we should all leave primary PCI, but if I have to use lysis, if primary PCI is not available to me, there is a very good option that can be followed, and you can be rest assured that you're not doing the wrong thing. And when we looked at the in-hospital mortality and MACE in the two arms of primary PCI on the left and pharmacoinvasive on the right, you can see that looking at the composite, at the odds ratios of the composite endpoint and the single endpoint, there's no difference. When it comes to major bleeding, it favors primary PCI, but still crosses the line of unity. And if you look at the 1-year mortality, again, it's the same with an odds ratio that does not favor one over the other. So in conclusion, Mr. Chairman, ladies and gentlemen, primary PCI is superior to fibrinolytic therapy when performed early. For many reasons, primary PCI can't be adopted, and we've seen that in our communities. And in Kuwait, we carried this over an entire year and tested different reperfusion strategies, and pharmacoinvasive for us proved efficient, effective, and safe. Thank you very much.
Thank you, Ahmed. Now, we will give the two questions to our remote audience. We will start with GHA branch in Yemen and let them give us their first question.
Hello, Bahl Yemen, and it's so nice to hear from them. We would have loved to have them here with us, but
شكرا جزيلا للأستاذ الدكتور حجر بن أحمد حجر بن علي، الأب الروحي لأطباء القلب في الخليج، وشكرا لما قدمتموه من تعاون في نقل فعاليات المؤتمر الهام لجمعية القلب الخليجية، وإن شاء الله نكون معكم في المرات القادمة. وشكرا للدكتور محمد زبيد المتحدث الرائع دائما. وحبيت فقط أقدم شكري لما قدمتم لنا في هذه الفعاليات ونقل هذه المحاضرات لإخوانكم الأطباء في اليمن. والسؤال سيكون للدكتور خالد القصاع. تفضل.
All of you, my question is Mohammed Zubair regarding the patient with pharmacoinvasive. Patient, for example, patient with pharmacoinvasive, if you ask for a patient, for example, 2-3 medical procedure. Of second question regarding if the patient with therapeutic therapy have resolution of ischemic cardiac infarction, no chest pain.
بعد الميكروفون شوي علشان نسمعك أحسن.
دكتور, if you maybe دكتور لو تبعد الميكروفون شوي عشان we could not hear what you said. ما سمعنا السؤال بوضوح.
السؤال question in patient with pharmacoinvasive. Did you add for the example in cath lab 2B3A? Second.
So that's the first question. Yes, there is. Yes, doctor. There is a percentage of patients who did receive glycoprotein 2B3A inhibitors in the cath lab, but honestly, I cannot tell you off the top of my head what percentage. So, yes, there some people did receive it, but I can't tell you how many.
Second question regarding if the patient had ischemic cardiac infarction, came early time within 1 hour, you give him therapeutic therapy, resolution of ischemic cardiac infarction, no chest pain. And this patient is for cath lab or conservative.
So if I understood the questions right, doctor, patient comes early You give thrombolytic therapy within an hour of chest pain, and then should you cath them? Well, according to the pharmacoinvasive therapy, yes, it's a good idea to cath them within 24 hours. And this is the guidelines now, Doctor, the guidelines from the ESC and ACC, that everybody who gets a STEMI, either they go for primary PCI, or if they get lysed, even if you lyse them early, do send them to the cath lab within the first 24 hours, if that's the question.
Thank you very much. Thank you very much.
Mashkourin.
Thank you. We will go now to our colleagues in Gaza.
Dr. Hajar, this is a first for GHA to have these satellites. The really great idea.
Good evening. I am Dr. Ayat from Gaza.
تفضل.
I am Dr. Ayat from Gaza. We thank GHA for this, for giving us this great opportunity to be with you in this interesting meeting. I asked Dr. Mohammed Zubayt about pharmacoinvasive approach. You want this approach for this point, if you did for them, pharmacoinvasive, the eye, how do you this as primary multiple disease? You have a multiple disease, you do calculation as in primary PCI, or you have another approach, as Kelvin and Kelvin shook trial, even in cardiology shock, in primary you do everything. You patient have primary multiple disease.
دكتور let me هد اللعب شوي. Slow down and take the microphone away, because I couldn't get the question. Anybody got the question, Chairman? Now maybe the Israelis are blocking your satellites. I don't know, but let's figure this out.
I would like to ask you about your approach in multi-vision disease and pharmacoinvasive strategy. Are you deal with this as plans are just help vision, or there is another strategy for
آسف دكتور والله ماني أقول لي بالعربي دكتور. Let's say it in Arabic, maybe it works different. And I'd love to answer the question, but just
multi-vision disease. الناس اللي عندهم multi-vision disease. invasive approach. نفس الطريقة في التعامل زي البرايمري، يعني نفتح فقط البرايمري الاربن ولا.
Okay, multi-vessel disease. شنو دكتور? What's the question? Okay, so so this is a patient you've given lysis for. This is the way we understood it. You've given lysis for, and now you've sent him for pharmacoinvasive, and he has multi-vessel disease. Should you deal with the culprit only, or do full revascularization at the time? Okay, I don't think this has anything to do with the pharmacoinvasive strategy per se. That's a completely different question, and definitely you're going to deal with the culprit. And as far as dealing with the culprit or other vessels, I think the literature is a bit conflicting on this issue. But personally, my practice, if I think if I fix the culprit and I'm happy about it, it looks nice and everything. If the non-culprits are not complicated, are not complex, I would love to finish them at the same time. If they're not complex, if they don't involve, possibility of injury to the myocardium or so. If it looks complex, the non-culprit, I would leave it and do it for some other day. But that has nothing to do with the pharmacoinvasive and non-pharmacoinvasive.
Thank you, Mohammed. Thank you very much.
Thank you very much. Thank you.
Proceed. As we start here, me and my co-chairman, we decided we will divide the speakers. I will take my friend and he take his friend. But during this period, I gain a third friend. So I will introduce to you my friend, Dr. Hoffman. He is assistant professor of preventive medicine and he is associate editor of JAMA Cardiology. Dr. Hoffman.
Thank you very much. I really appreciate the chance to present with you this afternoon. I'm excited because there was a question about polypills earlier in the morning, so hopefully I can answer that with some data. So I'll talk about the rationale, evidence, and progress to date. I have received funding from the Cochrane Collaboration to perform a systematic review update on polypills, and I have received travel funding from the World Heart Federation to attend a polypill meeting, so you should know those two important related disclosures. So the big question that I want you to be thinking about is when we have all these debates about polypills, good, bad, the other, is what is the problem that polypills are trying to solve? And I would argue that the principal problem is that generally in populations based in communities, we have low secondary prevention rates. These are data from the prospective urban-rural epidemiology study. On the left panel are individuals in communities, not in our clinics, not in our hospitals, but those are individuals in communities with prevalent coronary heart disease, and on the right are individuals with prevalent stroke. On the x-axis is different categories of countries participating in this study based upon per capita income. And on the y-axis is the proportion of individuals who are taking either no drugs, one drug, two drugs, or three or more drugs. So if you look at this, most people with prevalent coronary heart disease and prevalent stroke take no medicines to prevent a recurrent event, not even an aspirin. So I would argue this is the first and probably the most important problem that polypills are trying to solve. But it's not just a problem in low and middle income countries. In the United States, these are data from the National Health and Nutrition Examination Survey showing the proportion of individuals, again, in communities, not in my clinic or your clinic, who are taking aspirin, statin, beta blocker, or ACE or ARB over time from 1999 all the way to 2012. And even in 2012, in the United States, less than 1 out of every 4 individuals with prevalent coronary heart disease are taking the combination of aspirin, statin, and blood pressure lowering drugs. This is a global problem. It seems incredibly simple to recommend to patients to take these medicines, but the transmission of that advice to actually people taking this on a regular basis has been much more difficult than many of us have realized. So we have put together in the Lancet this past year a proposed guide for polypill uses and to think about how polypills could be studied and applied in clinical practice. So first I'll start in the left-hand column, secondary prevention. There is much less debate and conflict, but this could be under 2 conditions. One, we could have patients who are incompletely treated with recommended therapy, so we may use a fixed-dose combination of polypill to step up their treatment. And the key question here is, does polypill-based care lead to better adherence than usual care? And there are several trials shown on the right-hand column. Relatedly, we could perform a straight substitution of individuals who are already taking the recommended therapies for which a polypill would include. And here the question of clinical trials is, do the products have bioequivalence? Again, there have been several trials that have been published that have asked this question. Now we start to get into a little zone where there's a little more debate and discussion. So we think about high-risk primary prevention of atherosclerosis based upon a formal risk assessment. We heard earlier today about the inclusion of predicted risk in the treatment of hypertension. This has been the cornerstone of lipid treatment for the past 5 years. As we think about multivariable risk assessment, we need to think about multivariable risk treatment. And this could be for indications such as initiation, patient comes into the office for the first time, step up, or substitution. Now here the key question is, are the benefits of polypills greater than the risks compared with the individual components or usual care? And here again we have several clinical trials that have looked at this question. Now this last bucket, this is the one that has created so much controversy. This is primary prevention of atherosclerosis based upon a single risk factor measurement, such as age, for mass treatment. This was a tantalizing cover of the BMJ 15 years ago that got a lot of people interested, but there was actually a lot of blowback because people said, wait a minute, you're over-medicalizing the community. And here, the key question is, are the benefits of polypills greater than the risks compared with individual components or usual care? The only published clinical trial was a very small crossover by David Wald of less than 100 individuals. So this may be a way to structure not only our discussions, but research questions and clinical guide for polypills. So I ask you to think about a question. How would you design a polypill trial for cardiovascular disease prevention and control? It sounds really straightforward, doesn't it? When we think about these different buckets of which participants would you choose, the intervention, who would your comparator group be, what outcomes would you be looking for, over what period of time, and in what setting? So would you want to do primary or secondary prevention? What would you put in that polypill? Aspirin, clopidogrel, well, ticagrelor is BID, high intensity, moderate intensity statin, ACE, beta blocker, which combination? How about the comparator group? How do you compare against usual care? What is usual care? Do you pay for the individual components if you're comparing against individual drugs? And then what outcomes do you study? Adherence, risk factors, events? How long? Where do you do this? In New York, Chicago, Delhi, Tripoli? Whose standard of usual care should guide your clinical trial that you're designing? So you quickly see, boy, it gets pretty complicated pretty quickly when thinking about the clinical trials for polypills. So I've led the Cochrane Systematic Review and update in 2017, where we tried to cast a broad net. We looked at participants from both primary and secondary populations. We wanted a polypill that included at least one lipid-lowering and one blood pressure-lowering drug. There were some people who said, that's not a real polypill. We said, we just want to understand the evidence. We took any comparator. We had a broad range of outcomes, including mortality, events, adverse events, risk factors, and adherence. We also included any time course or setting. So in our 2014 review, we identified 9 clinical trials with more than 7,000 participants. And in our 2017 update, we identified 4 new trials with an additional 2,012 participants. This table demonstrates the list of clinical trials of polypills with the study name on the left-hand column, the content of the individual polypills in the middle column, and the comparator groups on the right-hand column. The trials that are bolded are ones that are secondary prevention populations. And what we can see is a lot of heterogeneity in the individual polypills that are tested, as well as the comparator groups. Some are active, some are usual care, some are even in TIPS, 8 other drug and drug combinations. We evaluate the risk of bias of the individual studies to evaluate their study limitations across domains such as selection, performance, detection, and attrition and reporting bias. And generally the studies were well done. Green meaning the low risk of bias, yellow an unclear risk of bias, and red a high risk of bias. And if you think about the key domain of blinding of participants, how would you blind an individual to usual care as a comparator group? You couldn't do that. So you would often blind your adjudication committee for your outcomes. This is a summary of findings table that tries to synthesize these trials in a format that uses data looking at relative and absolute events. I'm going to start by first identifying that the follow-up for most of these trials was under 2 years. So these are drugs that we're recommending for patients for oftentimes lifelong, yet the trials are relatively short-term thus far. Second, as we look at the number of events for an outcome such as all-cause mortality, we're only seeing about 1% in the usual care and 1% in the polypill arm. So this is a very uncommon event. These were relatively low-risk populations, and therefore, even though the risk ratio is 1.10, it crosses the line of unity. There was 5 studies looking at this outcome. The quality of evidence using the GRADE framework is considered low because we expect that future research is very likely to influence our confidence in this effect estimate. If we look at adherence, for example, we can see in the usual care or comparator arm an adherence rate of more than 50%. That contrasts with the adherence rates we see in populations in the United States, as well as other countries, including low and middle income countries, which is substantially lower. Despite that, we see a 44% higher risk or higher likelihood of individuals being adherent to medical therapy in the polypill group. This was reported in 4 studies with more than 3,800 participants. Here the quality of evidence is moderate, and in fact, future evidence may only strengthen this effect size. We do see subsequent reductions in systolic blood pressure and LDL cholesterol that demonstrate this adherence. I would note that there is a high degree of heterogeneity in these risk factor changes, so these results should be interpreted with caution. Now, the ASCVD events there seems to be a signal perhaps towards harm, but again, this is an uncommon event across the trials, not a whole lot of events, and therefore the quality of evidence is low. So I would say future research is needed to understand this outcome. So we looked at other things such as adverse events. Well, when your comparator group is placebo, we know that components of polypills increase the likelihood that participants can experience an adverse event. Aspirin leads to bleeding. ACE inhibitors lead to cough, and so on. Discontinuation rates were higher, but we could only include trials that did not have usual care as a comparator. How would you discontinue usual care? Quality of life was no different, and actually direct pharmacy costs were lower in one study reported in Australia. We looked across several subgroups and did not see any differences in events, risk factors, or adherence based upon those. This is a slide from Ruth Webster in the SPACE, or Single Pill to Avert Cardiovascular Events Collaboration, an individual participant data meta-analysis. On the y-axis is the proportion of individuals who are adherent to the medication, and on the x-axis is time. The left-hand panel demonstrates individuals who are adherent to no medications at baseline, and on the right-hand panel it's adherent to one medication at baseline. This slide is important in demonstrating that the individuals who are low adherers at baseline are the ones who are most likely to gain from fixed-dose combination of polypill therapy. Our patients who can handle the complicated TID regimens that we throw at them, they are not going to improve their adherence with polypills. They're going to be just fine. But it's actually the people who probably don't even come into our clinics who are the ones who are most likely to benefit. And so I would argue that this is another key group to think about polypill indicated for. Carlos Santo has performed a systematic review to evaluate strategies overall that improve adherence for secondary cardiovascular disease prevention. And she divides them into non-personnel-based strategies, which are arguably more scalable, and personnel-based strategies, which was based upon one study led by Michael Ho in the VA in the United States. So even compared with financial incentives, such as the MI-free trial or text messaging, polypills are the dominant strategy. So I think compared with personnel-based strategies, this is not a false dichotomy. It's not an either or. I think this is part of a package for a health system to be able to help patients who struggle to take their medicines take them more easily. In 2016, polypill was included in the HEARTS technical package. Whether or not this will be implemented in the context of the Resolve initiative remains to be determined. But this technical package noted that the use of polypills for secondary prevention and primary prevention in high-risk individuals for cardiovascular disease could close gaps in treatment of those conditions by reducing drug costs, improving adherence, and simplifying the drug regimen for patients who take them and healthcare workers who prescribe them. So we also identified barriers. While this idea has been around since 2001, at the WHO Wellcome Trust meeting where Richard Pito brought this idea forward, polypills are not widespread in most parts of the world. So we were asking what are research questions that would address barriers at the physician, patient, and pharmaceutical manufacturer level. Because without physicians, patients, and manufacturers interested in this will only be an academic exercise without real clinical applications. We also identified ongoing clinical trials and ongoing combinations using searches of clinical trial registers, and we identified more, not fewer polypills. We identified polypills where aspirin is now optional to capture a primary prevention population, given the uncertainty of benefits in that trade-off with bleeding in this population. We identified polypills with higher potency statins. For many patients, for many doctors, this was a big barrier to not have Atorva or Rasuva. And I would argue that more, not fewer, companies are investing in this space. So I want you to think about another question about what co-interventions would help potentiate the effects of polypills. They don't exist in a vacuum. They're not mailed to patients in most parts of the world. And there are large ongoing polypill trials that do include co-interventions. For example, the Integrate trial, which is looking at 8 different polypills, includes decision support and pharmacy support as a co-intervention. And in the high-risk primary population, the HOPE-4 study is looking at non-physician health workers as a co-intervention. The Poly-Iran study is the only study that we could identify that is using a mass treatment approach, and those results are awaiting publication. So in conclusion, rather than being a panacea for all, polypills represent the most effective and scalable intervention for improving adherence to multi-drug therapy for initiation, step-up, or substitution indications. Polypill trials have been generally designed to demonstrate bioequivalence rather than differences in clinical outcomes. High-quality usual care in trials limits power. And lastly, polypills are essential medicines for secondary ASCVD prevention, especially among low adherers. And the growth of polypill industry suggests an opening of the marketplace for these combinations. I'd like to acknowledge the help that I've received from my collaborators at Northwestern, London, the WHO, and Cochrane. And I'd like to thank you for your time and attention, and I'm happy to answer any questions.
Thank you, Dr. Hoffman. Now, he finished ahead of time, so we will allow one quick question. Yes.
So the question was about the patent, is that correct? Drug patents? Yeah, we actually did a patent analysis to understand, is this a barrier toward polypill development? And you can see it as a half full or half empty. So when a company has a patent on a combination, that actually means that there's an investment there that they're interested in pursuing. So that could be seen actually as a good thing. There is the other side of, well, will that patent be acknowledged and adhered to by other companies? And that is a potential risk. That hasn't been a big problem for Ferrer, is it's a medium-sized Spanish pharma company that has been perhaps the most successful at having the polypill available in more than 30 Latin American countries. So I think it's a theoretical risk and perhaps more of an opportunity, actually.
Thank you very much. The new assignment for our new GHA president, since he took the office, will be to speak now in this auditorium. Dr. Kavan Suleiman.
Thank you, Mr. Chairman. You can see that this slide says President-elect of GHA, because as you mentioned, I took over from Professor Zubayd 1 hour ago, and the slide is 3 hours old, so that's why it's an old slide. Sorry, I have to go back. Now, until recently, there have been very few publications about heart failure in the region. You can see the first few publications the first one from Oman, the other one from Yemen, and from Egypt, and they're all having a small number of patients, not really, you cannot generalize from them. The one before the last in 2011, the Hearts Registry came from Saudi Arabia. This is a large registry, but again, it's from a single country. And then we have the last one is the retrospective analysis from Qatar about heart failure in Qatar. So again, it's a single country data. Recently, we have got few publications. This is one meta-analysis of quite a large number of episodes of heart failure in low and middle income countries. However, only 1,550 episodes were from the Mediterranean region. You can see that these were the studies included in this analysis, 400 patients from Egypt, around another 400 from Iran, and then 180 from Lebanon and so on. So small studies included in this registry. Again, recently this was a large registry from Salim Youssef and his team, the Inter-CHF, and they looked at close to 6,000 patients of heart failure. However, only 1,000 patients were from Middle East, namely from 3 countries, Saudi Arabia, Emirates, and Egypt. So by far, the largest registry, including patients from the region, is our own registry, GulfCare, which included 5,005 patients from 7 countries in this region. And this, they were included from 47 sites of diverse hospitals. So there were university hospitals, community hospitals, and non-university teaching hospitals, as well as private hospitals. This is a distribution of patients. The majority of patients came from Yemen, almost a third of them, and then 20%, close to 20% from Oman and Saudi Arabia, and the rest distributed to the other countries in the region. Now we will see such slides repeatedly because the first 3 on the left side are patients from the Middle East. So the first one is GulfCare. The next is the meta-analysis from the Eastern Mediterranean region, and then the Middle East patients from Inter-CHF. And on the right side are the Western registries, the ADHERE and the European Heart Failure Registry. And the first striking thing you see here is that our patients are about 10 years younger than those reported in the Western literature. You can see they are not younger than Africa. Africa is still having younger than 53, the mean age, but compared to the Western literature, our patients are 10 years younger than them. The other striking thing is the proportion of patients having diabetes. Clearly, you can see that in our patients, more than 50% of our heart failure patients have diabetes compared to the Western registries, which is around 40%. The prevalence of hypertension in our patients is close to that reported in the Western literature, less than South America, but close to the rest of the world. And we are seeing now a lot of patients with high body mass index. Obesity is becoming a problem in our region. The other important thing to notice is the large proportion of patients with heart rate with reduced ejection fraction, whether in GulfCare or in the Middle East, patients from the Inter-CHF. And this probably reflects the higher proportion or the higher prevalence of coronary artery disease in our region, as I'll show you later. Here is the etiology of heart failure. In blue is the coronary artery disease. You can find whether you look at GulfCare or you look at Middle East patients from the Inter-CHF, about half of them having coronary artery disease as the etiology. And then around 18% is dilated cardiomyopathy. 10% in the Inter-CHF and 16% in our registry patients having hypertensive heart disease, and valvular heart disease around 9%. Compared to the other continents, you can see that in Asia it is still the same, the 50 or almost 50% having coronary artery disease as etiology, while if you look at Africa, it's only 20%, and the 35% are due to hypertension. In South America, it's only a quarter of patients having coronary artery disease, and the rest is distributed between the other causes. So ischemic heart disease as etiology, you can see we are indeed above 50%, very much close to the reports from the Western literature. Hypertension as etiology, if you look at GulfCare and the Middle East component of the inter-CHF, heart failure, hypertension as etiology is about 10 and 16%. It's very odd to see in the meta-analysis that 50% of patients having hypertensive heart disease. When we go deep into this meta-analysis, you will find they have gone into about 6 small studies, and you can see the first one of them is really very much taking it to the hypertension arm. Lebanon and Tunisia the same. So I don't think really we can depend on this meta-analysis to say that in the Middle East, hypertensive heart disease is a very common. In fact, it is coronary artery disease still number one. Hypertension is in the range of 15 to 20%. As precipitating causes, again, acute coronary syndrome is the most common precipitating cause in 27% of patients. Next comes non-compliance to medications, and infection is number 3. Uncontrolled hypertension is in 8%, and I think this is very important because this is totally preventable. And our colleagues in the primary health care, general practitioners, general physicians, I think this is a very important thing that controlling this, we can avoid 8% of patients admitted with heart failure. Regarding the use of medications on discharge, you can see beta blockers are used in about, again, you can see that Gulf Care and the Middle East part of the inter-CHF are very close to each other. The odd one is the meta-analysis, probably because they analyzed the studies with all the studies, and the use of beta blockers and ACE inhibitors was not common at that time. But overall, our use of beta blockers and ACE inhibitors is close to 80%, and this is actually very good, compared to the rest of the world. We're proud to say that we had 98.4% 3-month and 1-year follow-up in Gulf Care. And we did a 3-month follow-up, telephonic follow-up, while at 1 year we had 2/3 telephonic follow-up, and 1/3 we actually called patients and examined them in the clinic. And this is what we saw on medications on a discharge and at 12 months. So beta blockers on discharge 71% improved to 77% at 1 year. ACE inhibitors or ARBs improved again by 5% more. A mineral receptor antagonist again remained the same. Diuretics, still a large number of patients at 1 year taking diuretics. Still a quarter of patients taking digoxin at 1 year, and low use of ivabradine. Of course, at that time we didn't have the neprilysin inhibitor at that time, not available. The readmission rate at 3 months was 21%, and the cumulative readmission rate at 12 months was 42%, quite high. This is the mortality in hospital 3 months at 1 year and 1 year. If you look at the bottom, Gulf Care, almost identical to the Euro Heart Failure survey. This is Euro Heart Failure S2. In hospital, 6.3, and the European is 6.7. 3 months, there is a difference. We had 12.6%, the European had 8%, while 1 year is almost the same. But reminding you that our patients are 10 years younger than those reported in the European registry. So yes, the figure is similar, but the patients are quite younger. The EMR in hospital mortality, the meta-analysis was 7%, again, very similar to our data. This is the inter-CHF 12-month mortality. You look at it, it's quite low. It's about 9%. However, when you look at the factors influencing mortality, you can find that patients who were enrolled as inpatient had higher mortality than those enrolled from the clinic, because in this registry, patients were involved both from the clinic as well as inpatients. And if you look at compare the two, you can find that the inpatient, those who were involved while inpatient, the 1 year mortality was close around 18%, which is very close to our mortality of 20%. And the conclusion from the inter-CHF was that If you take everything together, Middle Eastern patients appear distinct from participants from other regions. They are younger, they have significant higher prevalence of obesity and diabetes, and higher rates of ischemic heart disease, ischemic cardiomyopathy, with depressed LV ejection fraction than heart failure from other regions. However, they say that since the great majority of Middle Eastern patients in the inter-CHF were from the Gulf countries, this observation may not be generalized to the rest of the Middle Eastern countries. Now, for this reason, we're now working with this new registry, the Peace MENA registry, which is a program for evaluation and assessment of cardiac event registry in the Middle East and North Africa. So we're trying to collect a large number of patients, both acute coronary syndrome as well as heart failure, patients who are admitted with heart failure, and follow them over a period of time from a large number of countries in the Middle East and North Africa. And we're just in the preparation phase. We'll start the pilot phase soon. So in conclusion from our and Gulf Care, as well as my conclusion from today's talk, is there are some good data about heart failure in the Middle East, particularly in the last few years. Middle East patients with heart failure are at least a decade younger than their Western counterparts and have much higher prevalence of diabetes. Ischemic heart disease is the most predominant etiology, and ACS and non-compliance to medications are the most common precipitating factors. There is good but still suboptimal use of evidence-based medications. Mortality rates are close to those reported in the Western literature, but should be evaluated in the light of the younger age of our patients. And we feel that there is a need to develop strategies at the national level to improve the care of heart failure patients. We have very few dedicated heart failure clinics in the region, very few heart failure specialists in the region. I think we need to look into that really carefully. This is a group of people from our region who took the initiative to try to put a roadmap for policy action from different countries in the region. And they came up with this, and I agree with most of their recommendations. They say that governments should work with health system leaders to lead national strategies for heart failure and fully integrate heart failure into cardiovascular disease and non-communicable disease plans. They raise public, patient, and professional awareness to understand heart failure, establish better measurements and data for heart failure, prepare a healthcare system for the rising burden of cardiovascular disease and heart failure. They also look at the health providers and system leaders should strive to recognize the importance of prevention of heart failure, as I mentioned, controlling hypertension, for example, achieve timely and accurate diagnosis, recognize the importance of monitoring and maintenance of heart failure outside the hospital, because you can see the one-year mortality is quite high. Ensure all patients receive guideline-based care while in hospital, and give patients adequate tools and support for self-monitoring and self-management. So I think it's a big problem, heart failure. We improve the treatment of acute coronary syndrome, of STEMI. Patients live, mortality is much less with acute coronary syndrome. Of course, survival is increasing, and a lot of patients eventually develop heart failure as they live longer. And I think, and it's not only, it has got a major economic burden on the healthcare system, and therefore we really should have national strategies to combat this heart failure. Thank you very much for your attention.
Thank you, Kevin. What amazed me in this conference is the attendance. At 5 o'clock, I was expecting most of you to run away, but still people walking in at this time of the day. I'm sure you are exhausted today, and Callum, I will request you to stay behind. Since this is GHA study, you could talk to people on person question instead of keeping the people longer. I would like to thank the speakers, the audience, and our colleagues in Gaza and Yemen for participating with us. It's too bad that I couldn't see the face of Ahmed Mtarrab and Dr. Abdel Nasser. From the camera, they must be sitting far away. Good evening, and we will see you in the next session.